Okay, Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, everyone. My name is Muhammad Hassanin. I'm a consultant endocrinologist and a professor of medicine in Gulf Medical University, and I'm the chair for the Diabetes and Ramadan International Alliance. It's a great pleasure to be with you on this workshop, along with my co-chair, Professor Gamal Belkhader, Professor of Medicine and Diabetes from Morocco, and he's also the president for the IDF MENA region for diabetes. Professor Jamal, great to have you with us tonight.
Thank you. Thank you, dear Professor Hassanin.
So tonight, inshallah, this is the IDF and DAR session on the best tips, the best practice, the workshop on the new guidelines that was recently launched just about 4 weeks ago for diabetes and Ramadan, the 2021. Tonight we have an excellent faculty of speakers. We'll introduce them in shortly, but it's just explaining to you that this session is done in every region globally with the support of our sponsors, Sanofi and Servier, without obviously any interference in the scientific content. So we're very grateful for our sponsors, and indeed we're grateful for the collaboration of DAR and IDF together. And before we start, we have actually a welcome video from the president of IDF, Professor Andrew Bolton, as well as from Professor Akhtar Hussain, the chair-elect for the IDF. So let's together hear their welcome message, and then we can introduce our agenda and the speakers for tonight.
Hello, and it's my great pleasure to welcome you to this workshop on diabetes and Ramadan. My name is Andrew Bolton, President of the International Diabetes Federation, and I'm delighted to say that I've been involved with this project really from its inception. The first international meeting of the Diabetes and Ramadan group was held here in my city of Manchester at the Islamic Heritage Centre of the UK back in 2013, when I addressed that meeting as President of the European Association for the Study of Diabetes. But since 2016, International Diabetes Federation has worked very closely with the Diabetes and Ramadan International Alliance to deliver comprehensive guidelines on diabetes and Ramadan. These are designed to help healthcare professionals advise and support those living with diabetes who wish to fast during the holy month of Ramadan. Patient education is, of course, critical to managing diabetes during this period. Educational needs need to be delivered in advance, so today's workshop is indeed timely. Providing education before Ramadan allows for any questions and concerns to be raised and addressed. These guidelines are, of course, of global relevance. We believe that there are probably around 500 million people living with diabetes across the world today, and this figure is set, sadly, to rise. The dramatic rise will be seen in many areas of the world with large Muslim populations, including some of our regions, Sub-Saharan Africa, Southeast Asia, and the Middle East and North African region. Because a large number of people choose to fast during Ramadan, there is a significant need for coherent and evidence-based practical guidance to help them and the healthcare professionals who support them to ensure a safe and healthy fast. As healthcare professionals, we need to understand the potential risks involved in fasting for those under our care. And we need to be well informed so we can deliver the latest evidence-based guidance on medication, glucose monitoring, nutrition, and exercise during this period. This second edition of the International Diabetes Federation and Diabetes and Ramadan Practical Guidelines aims to address these needs by providing the healthcare professionals across the world with latest evidence-based recommendations. It is my sincere hope and the sincere hope of all of us at IDF that these will contribute to supporting people with diabetes to safely and successfully participate in Ramadan should they choose so to do. On behalf of IDF, I really wish to thank my good friend and colleague Mohammed Hassinan from the United Arab Emirates for his tireless work throughout these years and in the editing of the guidelines and the distinguished team that he has gathered with him. I should also like to mention my friend and President-elect, Professor Akhtar Hussain, for his work done in overseeing this project on behalf of IDF. Naturally, none of this could occur without our friends and partners in both Sanofi and Servier for their generous support in making this possible. And of course, I wish to thank you, the participants, who are taking part in today's online workshop. Thank you.
I'm Professor Akhtar Hussain, President-elect of the International Diabetes Federation and Chair of the IDF Working Group on Diabetes Education. It is my great pleasure to welcome you all to this workshop. Fasting during Ramadan is very important practice for millions of Muslims around the world, but can have a major impact on the management of diabetes. While evidence is limited, some studies clearly show that many people living with diabetes choose to fast. The epidemiology of diabetes and Ramadan, AP-DAR study performed in 2010 found that about 43% of people with type 1 diabetes and about 79% of those with type 2 diabetes fasted for at least 15 days during Ramadan. Similarly, the 2010 CREED study reported that close to 95% participants with type 2 diabetes fasted for at least 15 days, and approaching about 65% fasted during the whole month of Holy Ramadan. So we know that people with diabetes will want to fast. However, we also know that an estimated 1 in 3 people with diabetes do not receive the education they need to fast safely. We are here today to help address this shortfall. I'm pleased to report that research on diabetes and Ramadan has increased tremendously over the past 5 years. However, there are still areas where further research will require to improve our understanding and answer some key questions. This can be what, for example, the most effective methods of providing Ramadan-focused education in different populations. What are the best possible nutrition plans for people with diabetes seeking to fast during Ramadan? And how can this be adapted for different regions across the world? Will advances in treatments and technologies help bring us closer to safe management while fasting? For people on insulin therapy who fast during Ramadan, what is the most appropriate type of regimen of insulin? I think we all can agree that diabetes self-management education and support is essential for safe fasting Ramadan. For this reason, the International Diabetes Federation and Diabetes Ramadan International Alliance have come together to raise awareness of the risks associated with diabetes and fasting and deliver the best available advice for health professionals. And this is why we are making the content available to the global diabetes community. In follow-up to the latest guidance you will hear today, we recommend you to visit IDF School of Diabetes website to learn more and access a dedicated free course on diabetes and Ramadan. Thank you all, and I wish you a very successful workshop.
Hello, everyone. Dear Professor Bulton, Professor Akhtar, Professor Hassanin, dear speakers, and all attendees. First of all, I want to express my great thanks to Professor Hassanin and his worldwide team for the great work about IDF-DAR guidelines on diabetes and Ramadan. As chair of IDF MENA region, it's a really deep pleasure and honor for me to be with you in this important virtual meeting for IDF-DAR MENA. The update of the IDF-DAR practical guidelines, first published in 2016, features new guidance based on greater and more recent body of evidence. This includes an updated set of criteria for risk stratification, information of the impact of fasting on physical and mental well-being, specific guidance on the management of type 1 and type 2 diabetes in special populations, such as pregnant women and the elderly, and information on change to the risk of comorbidities, such as cardiovascular disease, stroke, and renal impairment. These guidelines, which were produced with experts from around the world under the lead of Dr. Hassanin and including our speakers today, Dr. Ines Sheltout, Dr. Reem Al-Amoudi, and Dr. Bashar Effendi, are very important for supporting diabetic patients. They allow physicians to have objective tools based on scientific data to quantify the risks associated with fasting. They will contribute to supporting people with diabetes to safely and successfully participate in Ramadan and enjoy the personal and the spiritual benefits this can bring. I think that the next step is to communicate and disseminate easily these recommendations and these guidelines in different countries in MENA region. Many thanks again for your invitation and warm congratulations for all the team of IDF-DAR. At the end of my message, I wish a lot of success to this meeting and hope to meet you soon in conference face-to-face in MENA countries. Thank you for your attention. Now we are going to have a very interesting session about diabetes and Ramadan with Professor Hassanin and with three important speakers. Professor Hassanin will present pre-Ramadan assessment and risk scoring. Professor Ines Sheltout will present practical consideration for type 2 diabetes, oral hypoglycemic agent, and GLP-1 agonist, and Reem Al-Amoudi about the topic of insulin modification during Ramadan. The first speaker will be Professor Mohammed Hassanin, and Professor Mohammed Hassanin, it's a pleasure for me to present this expert and the president of the DAR, IDF-DAR. Dr. Hassanin is senior consultant in endocrinology and diabetes at Dubai Hospital. He holds an academic post of senior lecturer and associate director for postgraduate diabetes education, Cardiff University. His main research interest in the field of diabetes and Ramadan, and now we can say he's the president of it's the man of diabetes and Ramadan in the world. It's for me a pleasure and honor to work with him and to give him the talk about the first presentation, pre-Ramadan assessment and risk scoring.
Thank you very much, Professor Jamal. It's a great pleasure to be with the whole faculty who are all co-authors with me, Professor Ines, Dr. Reem, and Professor Jamal, and Professor Bashar Effendi. It's all a pleasure. I also would like to thank the colleagues from the Central Office of IDF, specifically Samir Pathan, who has tirelessly worked with us to get these activities going. And that's obviously all the colleagues in the office as well have worked very hard to get this reality. Let's go to the scientific part, which you're all here for. So my session is looking into 2 points, the benefits and the risks of fasting, and then the risk scoring and the assessment we need for Ramadan. I will try to be as quick as possible. I would like to acknowledge the authors of the different sections of what I will present, and you can find the full information for the presentations on the IDF or the DAR websites. So, of course, you all are in the MENA region, you all are aware of the importance of Ramadan as a month for all of us. It's a very important month for Muslims, and indeed, people with diabetes are among them. Of course, Ramadan carries a spiritual aspect, and any good deeds done during the month counts at a much higher level. But not just religious aspects, but Ramadan is a social time where we all get together, meet each other, see our families and friends, and have lots of social activities and community activities and charity activities. And because of all this, the mental well-being of the person during Ramadan very frequently is better. Less stress, less anxiety, and better mood. But that's not the case for everyone, because the person who is having difficulties to fast might have more stress, more anxiety, and a low mood. So it's important that we try to look for all of these people. During the month of Ramadan, there is recent evidence to tell us that there is physical benefits. Recent data are showing a reduction in weight, a reduction in glycemic parameters, lipid parameters, blood pressure, and much of this also could translate into better outcome for fatty liver disease. Unfortunately, Ramadan is only 1 month, so all of these benefits disappear a couple of months or a month later, so it's not necessarily sustained. But perhaps it provides like a pause, like a month of cleansing the body from some of the harmful effects that we have throughout the year. But that's not the case still for everyone, because there are some people who could face during Ramadan, who are people with diabetes, significant hypoglycemia, hyperglycemia, ketoacidosis, dehydration, which can lead to thrombosis, at least as a theoretical possibility. This is the old risk categories. And as you can see, it used to be like a table of red, yellow, or green. And within the table, you would have some people within that table. But reality is saying to us, that's not necessarily the case. There are some people with diabetes who perhaps we as clinicians say they are high risk, but experience is saying they are able to fast. So how can we make that differentiation? Myself and my colleague, Dr. Bashar Effendi, who were partners in this particular paper, led by Dr. Bashar, where we looked into a number of factors that can impact on the risk stratification. And I've highlighted some of these points that I will try to address during my presentation. Take, for example, length of fasting hours. So this is a study that we recently published called the Orion study, looking into glargine 300 in nearly 500 persons. The vast majority of them were from the MENA region as well as India and Pakistan. Only a small number, 25 persons, were from Canada. But look into the rates of hypoglycemia. 6 out of the 25 in Canada developed hypoglycemia, while 7 out of 477 in the others developed hypoglycemia. So clearly the hypoglycemia in Canada was much higher. Why? We don't know, but we can predict that maybe this is related to the hours of fasting. Maybe our working circumstances are adjusted in Muslim majority countries such as MENA region. That's not necessarily the case in Western society. Maybe it's related to temperature. So many factors that could be interacting. And that's one of the important parameters that you need to think of as a clinician when you risk quantify for your individual. Then come the type of diabetes. Look here, the data from a global survey that we did last year, which was answered by nearly 8,000 persons. For type 1 diabetes, those who did not fast is 30%, while in type 2 diabetes, only 16% did not fast. And clearly, you can see the hypoglycemia also varies massively. Daytime mild hypoglycemia occurs in 62%, nearly 2/3 of the people with type 1 diabetes versus 15% of people with type 2 diabetes. The severe ones did not differ too much between the types of diabetes. Look into another important point, the ability of the person to complete the month. So while in the past we were saying type 1 diabetes cannot fast, well, here is some evidence that some of them can. Indeed, 27% did, and even 27% had no hypoglycemia. So it is not the glass is half full or the glass is half empty. We need to describe the glass with how much water in it as it is. And the new risk scoring is trying to help us with this. When it comes to therapy, clearly from data that we had in Crete, as well as in the recent Darmina trial, that therapy matters. If a person is on insulin, the risk of hypoglycemia is much higher. Equally, if they're on sulfonylurea, the risk of hypoglycemia is higher than those who are not. At least that is for general sulfonylurea. You will see from future presentation during the day some of the differences between different types of sulfonylurea. But one very important point we saw in CREED trial. Over the next few weeks, when you meet someone with currently who are having hypoglycemia, you know that that person likelihood of having hypoglycemia when they fast is much higher, even more than the comparison of whether they are on insulin or not, or which region they're in. So that's quite an important factor. That person, we need to work hard to try to get their risk lower. So as you can see here, comorbidities are also an important factor. This is a study that we did in my hospital in Dubai with the input of all my colleagues in the same department. We looked into optimum care for people with stable coronary heart disease. And as you can see, those who improved from glycemic point of view were only 10%. Those who worsened were 71%. That's from the hypoglycemia point of view. However, it is important to remember that in our study, as well as in smaller number of studies, we did not see an increase in cardiac events during the month of Ramadan. The data is not enough to have that as conclusive as we would like to say it. So what about age? Does age matter? Well, people who've older age, by nature, they probably will have diabetes for a longer duration. And we saw from the data from the survey that more of them were unable to fast. So 28% decided not to fast versus 12% in type 2 diabetes. And indeed, we saw a much higher rates of hypoglycemia leading to going to the hospital in them. So clearly, age matter as well. And based on this, we, in the chapter for the risk stratification, we have put what we call a risk score. We've put different items, as you can see here, and for each item, we have put a score. I say we because this was shared with the general authors of the guidelines, as well as during a survey. We hope that this will be a good tool. Here is more of the risk categories, and as you can see, it includes complications, chronic or acute, pregnancy. Now, pregnancy is an important point because a pregnant woman or a breastfeeding woman has the automatic right not to fast. So that is not an issue at all. If this lady insists on fasting, then based on her clinical parameters, you will be able to put a score for that matter. Of course, with all of this, it means that appropriate monitoring is also quite important. Indeed, the lifestyle of the individual, how many hours of fasting, what is the nature of their job? Is it intensive physical work or a sedentary job or something in between? And then what about their mental status as well as their age? Are they frail, regardless of their age? Are they living on their own and also with older age? All of these are very important points. And then lastly, the individual own experience. You might feel that the person have no problems, but the feedback from the person that he or she had serious problem last year or the opposite is an important point to also consider. So based on all of this, you calculate the score for the individual and it comes as 0 to 3, 3.5 to 6, or above 6. Obviously, it could be as high as double figures. And based on this, you give the person the level of the risk. Now, the beauty is we have the harmony from the religious authorities in the format of the Mufti of Egypt. And the Dar al-Ifta, the Mufti of Egypt, is the highest authority for religious regulation, and they are professors from Al-Azhar University. They base their opinion based on our advice. So largely, this is the scientific opinion where they base their opinion on. But the principles, they did their opinion on 2 points. One, avoiding hardship. So in Arabic, this is the point of عَلَى الَّذِينَ يُطِيقُونَهُ, being able to tolerate the fasting. The second point is eliminating the potentials of harm. وَلَا تَلْقُبْ أَنفُسْكُمْ إِلَى التَّهْلُكَةِ. That's what the Quran says, and that's in many hadith of the Prophet Muhammad sallallahu alaihi wasallam. So it's important that we remember this. So fasting is obligatory for those who are at low risk, but if you as a clinician with the discussion of your patient feel that this person needs to eat or drink on a regular basis or need to have medication on a regular basis, then your advice would change that score. For the 3.5 to 6, fasting is preferred, but still, if after careful assessment of the clinical scenario, you find that this person is better not to fast, then you can advise them to do so, and they have the religious exemption from the fatwa. If they wanted to fast, it's important that they follow the medical recommendations that you said, including the regular monitoring. Clearly, those that you say to them they are high risk, they are advised not to fast, and strongly advised not to fast as well. So with all of this, what you need is an assessment before Ramadan. You put all the elements together, you come with a score, and then you revisit how can this score change? Perhaps changing medication or frequency of monitoring or glycemic level could improve or could get worse. So all of this is a dynamic situation. We hope to have this information for you as an app online where you can be sitting in clinic and you can log in and you can tap the points and come with the score. So the pre-Ramadan assessment is really quite important that you would take in it all of these important points and make your patient understand all of these aspects. Education is not just for our patients. Of course, they are the targets or the highest target, but we are all now in an educational session. And equally, we need to extend the education to the general public, including community and religious leaders. Because if I am a journalist or a media person and in TV or an imam, and I say something to the contrary of what we as medics say, the patient is likely to believe them more than us. Education works, and the meta-analysis is showing to us, even in a short time of Ramadan, HbA1c improved because of education. So, of course, we need to do the risk assessment, the treatment modification, the monitoring, the different aspects of nutrition, the management therapy, and advice on to break the fast. Ramadan is an opportunity to extend the education throughout the year. SMBG is crucial in Ramadan. We're not saying the person should do 7 times. The frequency and the timing varies from a person to person, and you will be able to advise your patient on the best time. But don't forget the vulnerable time, which is late afternoon to evening. In many cases, that is quite vulnerable. Of course, again, I repeat, it depends on the type of diabetes and the lifestyle of the individuals. In some other countries, that part of the day, post-suhoor, could also be an important part. So get your patient to understand they need to break their fast if they have low blood glucose readings or if they have low blood glucose symptoms, and reinforce the symptoms for them again. Don't forget, education can happen in many ways. I'm delighted that the IDF have set modules for the education, which was very well attended, and I'm sure we can still all benefit from this, as well as the electronic information we have on the DAR website, as well as the application, whether the patient application or the healthcare professional applications. So finally, Mr. Chairman, ladies and gentlemen, fasting during the month of Ramadan is a religious obligation for all healthy adults. However, the Islamic regulations exempt many people, which could extend to some people with diabetes. Our job is to risk quantify and stratify our patients on an individual basis. With the right guidance, many people will be able to fast safely, but equally, we will all be able also to find those who are high risk and tell them in a frank fashion that they should not fast. Our guidelines are endorsed by the highest religious authorities from Egypt, and perhaps you in your countries can take this further with your local religious authorities. Individuals who fast against the advice provided by healthcare professionals should ask their experts on the best guidance on what to do and follow that guidance carefully. Pre-Ramadan assessment and education is a very important tool. Here are the main references, and indeed, the most important reference is the guidelines itself. Thank you all, and I stop sharing my presentation and hand over to our chairman.
Thank you, dear Professor Hassanin, for this important intervention about pre-Ramadan assessment and risk scoring. You have precise some important points about risk versus benefits of fasting, risk scoring and religious view, role of pre-Ramadan education, and blood glucose monitoring when and how. I think some questions can be discussed after at the end of the meeting with the other speakers. Now, it's a pleasure for me to present Professor Ines Sheltout. Professor Ines Sheltout is Professor of Internal Medicine and Diabetes at Cairo University. She is the president of the Arabic Association for the Study of Diabetes and Metabolism. Professor Ines Sheltout is very active in research and in social activities and in MENA region, and she is leading the working group of survey in MENA region. She has done several published research in the field of internal medicine and diabetes, and he organized every year beautiful meeting and congress in Cairo. She has to explain for us the practical consideration of type 2 oral hypoglycemic agent and about GLP-1 receptor agonist. Professor Ines Sheltout, you have the floor.
Thank you, Mr. Chairman, Professor Jamal, for this introduction and for invitation. And let me talk about some practical guidelines on diabetes and Ramadan. And this is acknowledgement for the authors of this chapter, Practical Guidelines. Health issues related to fasting during Ramadan are many, causing hyperglycemia, hypoglycemia, or dehydration, and those health issues are large meals, more than 1,500 calories per meal, large amount of carbohydrate intake, sugary dessert, soft drink, juices, large and frequent snacks, eating too quickly, eating sahur early, large amount of high glycemic index, carbohydrates, fried foods, and changes in exercise and sleeping patterns. So there should be a pre-Ramadan assessment for the patients, and the pre-Ramadan assessment should include medical nutrition therapy. Medical nutrition therapy can improve the glycemic control, and we should give our patients information how to prevent dehydration and other related complications during fasting, and individualized nutritional plan to each of these patients with diabetes, either to maintain the weight or to reduce the weight, possibly during Ramadan, and to help individuals to lose weight when it is a target. And these are the caloric targets during Ramadan, and to give the patient a sahur with a percentage of calories 30 to 40%, the iftar meal 40 to 50%, and 2 snacks 10 to 20% of the total daily calorie. And for daily caloric intake, it should be adjusted according to whether weight maintenance or weight reduction is required. And this is an example of a Ramadan meal with 1 or 1.5 cup of whole grain rice, 1/3 a cup of beans or lentils or peas, 1 cup of vegetable, and around 100-120 grams of lean protein, 2 glasses of water at least with iftar, and a slice of fruit like watermelon or another type of fruit. For medical management, the risks are either hypoglycemia or hyperglycemia with different anti-diabetic medications, whether oral or injectable anti-diabetic medications, and these are the different groups of anti-diabetic medications. And for those patients on metformin, has less risk for severe hypoglycemia or rare risk of severe hypoglycemia. And if the patient is given metformin once daily, no dose modification is required, and it is to be taken at iftar. If it is given twice daily, again, no dose modification is required, and it can be taken with iftar and sahur. And if it is given 3 times daily, morning dose to be taken before sahur, and to combine the other 2 doses with iftar. For those taking prolonged release metformin, no dose modification is required, and the dose to be taken with iftar. For those patients on for those patients on thiazolidinediones, there is low risk for hypoglycemia, and no dose modification is required, but the dose should be taken with iftar. For patients on short-acting insulin secretagogue, studies showed that there is low risk of hypoglycemia during fasting, and if the patient is taking 3 doses, the dose should be reduced or redistributed to 2 meals, or on the same dose is divided on the 2 meals, or to reduce the dose to half the dose to iftar and half dose with suhoor. For those patients using DPP-4 inhibitors seem to be attractive medications for the use of diabetics during Ramadan, because there is no risk of severe hypoglycemia, and there is no dose adjustment needed, and there was different trials on sitagliptin and vildagliptin showed safety of use during fasting Ramadan. For sulfonylurea, there is risk of hypoglycemia, especially with older medications like glipenclamide. And this study was published in 2011, showed symptomatic hypoglycemia. It was maximum with glipenclamide 25%, followed by glimepiride 16%, followed by glyclazide 14%. And severe events of hypoglycemia happened in 10% of glipenclamide cases, 5% of glimepiride cases, and 2.6% of glyclazide cases. The risk of hypoglycemia is higher with insulin secretagogues, and those are studies again done more recently during Ramadan, and showed that glyclazide MR was safe during Ramadan, and the incidence of hypoglycemia was 1.7% in cases of glyclazide MR, and there was no severe cases of hypoglycemia during or after Ramadan. So if sulfonylurea are being used, glyclazide MR and glimepiride are preferred over older classes like glipenclamide. And if It is taken once daily dosing. It is to be taken at iftar. And in individuals with well-controlled blood glucose level, dose may be reduced. And if given twice daily dosing, we should take the whole dose of iftar, the same dose like before Ramadan, and the suhoor dose to be divided, preferably if the patient is well adjusted. For older drugs like glipenclamide, it is better to shift to glyclazide or glyclazide MR or glimepiride instead. For SGLT2 inhibitors, different trials was done on canagliflozin, dapagliflozin, and those studies showed that SGLT2 inhibitors have a low risk of hypoglycemia and no dose adjustment is required during Ramadan. But SGLT2 should be started at least 2 to 4 weeks before Ramadan, and they are recommended to be administered at the time of evening meal. And it is recommended to increase fluid intake for fear of hypovolemia or dehydration during Ramadan, especially in elderly diabetics. And let me finish the anti-diabetic medications with the GLP-1 receptor agonist and the risk of hypoglycemia with GLP-1 receptor agonist is low. But when combined with sulfonylureas, there may be increased risk for hypoglycemia, and those were 2 studies done on lexisenatide and liraglutide. And as long as the liraglutide, the lexisenatide, exenatide is well titrated before Ramadan, at least 2 to 4 weeks before Ramadan, there is no further treatment modification required. Those are the summary of the considerations. Many patients with multiple anti-diabetic agents have a long duration of diabetes and multiple comorbidities with renal impairment. They are more prone to the risk of hypoglycemia when fasting during Ramadan. And for type 2 diabetes on 3 or more anti-diabetic medications who wish to fast Ramadan, they should receive counseling and advice on diet, lifestyle, and drug modification before Ramadan. And those on 3 medications or more drug medication, especially those on insulin and sulfonylurea, the insulin dose is better to be reduced 25 to 50% before Ramadan, and maybe also reduction in the dose of sulfonylurea. New technology like continuous glucose monitoring may be used for fear of hypoglycemia. And let me summarize and conclude with those statements. Individuals taking sulfonylurea, insulin secretagogue, will need to make dose adjustment to reduce the risk of hypoglycemia. And individuals on multiple anti-diabetic medication will find themselves at greater risk of hypoglycemia, and counseling is recommended. Dose reduction may be needed to accommodate for increased risk of hypoglycemia, and a post-Ramadan follow-up is needed to readjust the dose and to reassess the treatment schedule with the correct advice and support of healthcare professionals. Most people with type 2 diabetes can fast safely during Ramadan, and these are the references of the guidelines and the practical recommendations, and thank you.
Thank you very much, Professor Ines. Very clear presentation. So now it gives me great pleasure to introduce my friend and good colleague, Dr. Rima Al-Amoudi. Dr. Rima Al-Amoudi is a consultant of diabetes and endocrinology at King Abdulaziz Medical City National Guard Hospital in Jeddah. She's a graduate of King Abdulaziz University in Jeddah, and she went to Canada from Vancouver for her fellowship and her training, where she obtained her clinical work as well as her master degree. She's an honorary assistant professor in King Faisal University in Al-Hassa, and she's the head of internal medicine, medical division of the National Guard, the MEM Hospital, from 2015 to 2017. She's been very active in the field of Ramadan and the research on Ramadan, particularly in type 1 management, and been one of those people with great interest in many studies involving this. She will today address for our third session the aspects of insulin management in type 2 and in type 1 diabetes patients, including the pump patients. Dr. Reem, we're all looking forward to your presentation.
Okay, Bismillahirrahmanirrahim. Thank you very much, Dr. Really kind introduction. And thank you for all your efforts that you do for diabetes and Ramadan and for the DAR guidelines and for bringing it now to the audience. And thank you for all the audience who are with us who are interested in diabetes and Ramadan. Bismillahirrahmanirrahim. So I'm going to be talking about the part of the guidelines that deals with insulin therapy in patients who wish to fast Ramadan. And so start with acknowledging our colleagues who contributed to the chapter of management of type 2 diabetes, and we're mainly presenting here the guidelines on insulin management from that chapter. So questions that we would like to answer through this talk in relation to insulin is, so number one, what do we know about the safety of using insulin and fasting, or how safe is it for patients who are on insulin to fast? Are there differences between different types of insulin in regards to that? So analogs versus human, and which regimen is better? If we are going to use insulin or allow our patients to fast while on insulin, how should we be adjusting the doses at the start of Ramadan, and how should we be titrating it during Ramadan? And we'll just go over in the guidelines to see what's new in this year's DAR compared to 2016. So as you have all seen in the first talk, the most important part of these guidelines or what's new in these guidelines is in regards to risk stratification. And while in the previous ones, insulin used to be in the should not and must not category, now it's not automatically assessed as something that increases the risk, and it should be weighted according to the type of regimen. And as you can see here, when it comes to scoring, actually the mixed regimens, if given more than once a day, get a bigger score of 3 compared to MDI, and then with the least being for those on basal insulin regimens. We know from DAR-MINA of type 2 diabetes overall that patients who are on insulin compared to those who are on oral do have higher rates of hypoglycemia during Ramadan. However, still most of them do fast safely. And in this study that looked into the optimum diabetes care and safety of patients in type 2 diabetes on insulin therapy, and in this study they had patients put on flash CGMs, and you see that there is kind of like a trend for more or longer duration of hypos in patients who are in intensive therapy compared to those who are on basal, and a little bit more for those who are intensive compared to those who are on basal in regards to having severe hypos of less than 50. The difference was not statistically significant. So how can we adjust insulin therapy, and how do we individualize treatment for patients who are on insulin? Should they continue whatever they are on, or should we adjust the doses? Is it just adjusting the doses, or should we also be adjusting the timing of taking those doses? Should we be changing it to a different regimen or different combinations from what they're on? Or should we be doing all of the above? So before we go to what the guidelines say, things to consider, and again highlighted through the guidelines, is that regardless of what we say, patients who want to fast will fast, regardless of they are on insulin therapy or other, and irrespective of the risk, even if you advise them against it. And while the primary focus on the risk is hypoglycemia, but again, we should also be taking care of the overall glycemic control and avoiding hyperglycemia during Ramadan. The regimen has to be individualized, and it should take into account the background education and the education given to the patient, preferences of the patient, the type of lifestyle and diet and culture that the patient comes from. There are authors who have recommended switching to the twice daily premixed or the intermediate acting insulin to long acting insulins or intermediate acting insulins during Ramadan, or what you call the modified basal bolus. However, overall, it's not generally recommended to change the regimen just for the sake of Ramadan, because that can lead to a lot of errors. It does require a lot of additional education, and it might not be the best way to go. Now, the individual's pre-Ramadan glycemic control does determine how much dose reduction and how much adjustment would be needed when they are fasting. So what does the guidelines say in regards to basal insulin therapy? We know from many observational trials that basal alone does seem to be quite safe when used combined with oral agents. And when it comes to the basal, the analog type basals seem to be better than the human. And it has to be always pointed out to patients that taking insulin by subcutaneous route or IM does not cause breaking of the fast, because this is a common misconception. Now, when it comes to the basal type insulins, the new longer acting or insulins like the Glargine 300 has showed to be more effective both in controlling the blood sugar and with much less hypoglycemia rates. The patients from the Orient trial did fast the full month of Ramadan with very low incidence of systematic hypoglycemia, no severe hypoglycemia whatsoever. So it did demonstrate to be quite successful during Ramadan, and even when titration and intensification was applied. What about combining basal insulin to injectables like GLP-1s? So there's been, again, a number of studies that have looked into that. A study that looked into liraglutide plus insulin versus sulfonylurea plus insulin, and another one that looked into lixisenatide plus insulin. And both have showed that this type of combination does seem to be quite safe with low rates of hypoglycemia during Ramadan compared to the combination of sulfonylurea with basal insulins. In this study that compared lixisenatide with basal compared to sulfonylurea with basal, you could see very clearly that the risk of all types of hypoglycemia, whether on the treatment, even pre-Ramadan or during the fasting, were much lower when it was the combination of lixi plus the basal compared to sulfonylurea plus the basal. So this is about, we just finished talking about basal. What about prandial insulin? So again, even with prandial, the analogs seem to perform much better compared to human insulin. They have or are associated with much less risks of hypoglycemia and even much better postprandial hyperglycemia control. And they have the convenience of being able to be taken right before the meal or even after the meal, which again is very convenient for many patients. Pre-mixed insulins, now these are quite common, probably the commonest type of insulin regimens that are used in many countries. They are available in many different ratios, of the short rapid being 25 or 30%, and the intermediate or long acting being 70-75%. And the main problem with pre-mixed is this fixed ratio. And a lot of our patients, especially with Ramadan, would require much higher ratio of short acting to cover the iftar period compared to the sahur period. So having the mixes at the combinations of the lower ratio of 25 to 30% might not be appropriate for that kind of meal. And there has been some studies that looked into to giving patients the 50-50 type mix at the iftar versus the 25 or the 30-70 at sahur time. And it did found to be much better in controlling the post-iftar blood sugar. So these are the options when using them. You can use either a higher ratio of premixed at iftar, or you can change the whole regimen to basal plus prandial or basal plus GLP during Ramadan. Now, in a study that compared the new combinations of the prolonged analog, the IDIG aspart, 70% with, which is basically 70% digludec with 30% aspart, it was again here, compared to the biphasic aspart, and it did show that it performed much better in regards to glycemic control, but there was no statistical difference in regards to hypoglycemia between the two regimens. There was no difference in glycemic control, but there was a lower incidence of overall hypoglycemia. So what do the guidelines tell us to specifically do in regards to patients who are premixed? So generally speaking, there's a very nice table given for the exact titration that depends on the fasting, pre-iftar, or pre-sahur blood sugar. For patients who are only on one dose, all they need to do is just take that dose normally at iftar. For those who take it twice a day, they can take their normal dose at iftar, but they should or are recommended to reduce their sahur dose by 20 to 50%, and that amount that you reduce would depend on the previous control before Ramadan, the amount of food that he takes with sahur, previous Ramadan experiences. All those factors come in when you're deciding to exactly how much you should be reducing that sahur dose. For those who take 3 times a day, they're usually advised to omit the middle or lunch dose and just take the first and last dose, one with iftar and one with sahur, and then carry dose titration every 3 days according to this table. So if you notice, this table gives you specific advice if the fasting or pre-iftar, is less than 70, less than 90, to go up or go down by 2-4 units. However, for patients who are on much larger doses, this might not do, and probably in that case, it would be better to go by percentage of 10 to 20%, depending on the dose that they're using. Now, what about for those who are on MDI? Combination of long and short actings or intermediate and short actings. So if they're taking once a day long acting and their pre-Ramadan blood sugar is well controlled, they're advised to reduce that by 15 to 30% and to take it at iftar. If they're taking a twice a day regimen of Detamir or MPH, or even glargine, because some patients do take twice a day glargine, they're advised to take the usual morning dose at iftar and reduce the evening dose by 50% and take it at sahur. And for the short acting or the prandial, now if here it's it's mainly we're talking about when to take it. So they should be taking normal dose at iftar, omit the lunch dose, and reduce the sahur dose by 25 to 50%. However, I would say if this is, in general, if they're taking fixed doses, but if they are the type of patient who are taking the short acting depending on carb count, they should be able to continue applying the same carb count method during Ramadan. Now, again, this table provides some suggestions and recommendations and guidance towards how the during Ramadan titration should go. So depending on the fasting, whether it's low or high, you would either go up or down by 2 to 4 units, depending on the target. The target for fasting is 90 to 126. And again, these type of adjustments by 2 to 4 units apply for patients who are on smaller doses. For those who are on very high doses, a change depending on the percentage of 10 to 20% might be more meaningful in those cases. So what about patients who are on insulin pump? Now, overall, we know that patients on pump do a bit better with fasting. studies have shown that being on pump does reduce the risk of hypoglycemia as well as hyperglycemia or better glycemic control during Ramadan. In a meta-analysis of type 1 diabetes that showed that those who are on insulin pump or CSII had much lower rates of severe hypoglycemia, hyperglycemia, and DKA. And those who are even on the more upgraded sensor augmented pumps and closed loop systems do even much better. And there's a number of studies that show that they manage to fast the whole month without any complications. Overall, the general advice is that during Ramadan, the basal rate needs adjustment. So for the latest part of the day, the 3-4 hours before Maghrib, it's advised that the basal rate should be reduced by 20 to 40%. And on the other hand, after Maghrib, the first 3-4 hours, the basal rate is advised to be increased by about 0 to 20%. When it comes to prandial or bolus doses, they should be applying the same normal carbohydrate counting and insulin sensitivity principles that they usually apply pre-Ramadan. Now, again, to emphasize that probably the most important thing during Ramadan for anybody who takes any sort of insulin is the monitoring. And whether it's by SMBG, the number of times that they need to do it would depend on the type and the intensity of the regimen, from twice or to 3 times a day to 7 times a day, depending. For those who could afford these flash CGMs or the other form of continuous glucose monitoring, again, they have been shown to be really beneficial for patients during fasting. And for those patients, for sure, more education is needed into how to use them and how to do adjustments, taking the information they get through these CGMs and applying these for the titration of whatever regimen they are on. So for those who would be fasting Ramadan for the first time, a trial fast before Ramadan to try things out is probably a good idea. So they could fast for 3 days, and therefore during that test themselves, detecting their own risk of hypoglycemia, and guide the self-titration of insulin doses, and that would help identify issues in regarding to fasting hypo or hyperglycemia or postprandial hyperglycemias, and extrapolate from that all the information that is needed to apply when Ramadan comes. Probably it would be better for it to be done closer to Ramadan, so that the length of the fast is closer to what the actual length of fast would be. And a good time would be 3 الأيام البيض اللي في شعبان 13 14 15. They might be a suitable time for such a trial. So in summary, I think I've shown you that insulin can be used safely in appropriately selected patients. We do have evidence for the recent types of longer-acting insulin analogs to be associated with much lower risks of hypoglycemia. However, insulin therapy must be individualized for all patients, considering what their baseline control was before Ramadan, the level of dedication that they have and dedication, the preferences and the type of diet that they usually go on during Ramadan, the type of work, working hours, sleeping hours, all these things have to be taken into consideration when individualizing the regimen. And more importantly, that it doesn't stop just by the start dose decision, but self-titration and monitoring are essential during Ramadan to be able to safely fast, both avoiding hypoglycemia and avoiding hyperglycemia. And with that, I conclude. These are the references used for this chapter. And again, to acknowledge my colleagues who wrote this section in the DAR guidelines. Thank you very much.
Thank you very much, Dr. Reem. It's a great pleasure to have you presenting the data on the insulin management for people with type 2 diabetes. Now we come to the last session of this workshop, and it's my delight to introduce a very good friend of mine and colleague, Professor Bashar Effendi from Tawam Hospital in Al Ain, UAE. Bashar is Syrian by birth. He graduated from Syria, moved to New York for his training, and then came to UAE for his consultant post. He's a professor in Al Ain University, as well as affiliation with Johns Hopkins University in USA. He has plenty of research in the field of Ramadan, numerous studies, and he's a co-author in several of the chapters of the latest IDF guidelines. But Bashar will address the area of special population, the pregnant women, the elderly, and those with kidney or cardiac problems. Bashar, over to you.
Assalamu alaikum. Thank you, Dr. Hassanin. It's my pleasure to be a part of this great effort. My task is, as you mentioned, Dr. Hassanin, is to discuss the management of patients with high risk, patients with diabetes and cardiovascular disease, patients with chronic kidney disease, hyperglycemia in pregnancy, and elderly with diabetes. Okay, so these are high-risk patients because of the conditions they have, placed them at the higher risk for developing complications. Now, as you know, the decision to fast or not to fast is not only based on medical recommendations. There are many other factors. We actually reported that 40% of our patients do fast without even consulting with any physician. We also reported that 78% of our high-risk patients, they fast against medical advice. So it's not only about medical decisions. There are many other factors. That's why pre-Ramadan evaluation actually is essential for proper evaluation of patients and consequently safe fasting. However, unfortunately, only about 2/3 of patients get this formal education session before Ramadan. A structured education program before Ramadan would mean that you have to discuss with your patient the risk for him if he fasts, to discuss the importance of SMBG, treatment modification, diet and physical activity, management of complications, including acute complications, hypo and hyperglycemia, and very important, when to break the fast if they insist on fasting or if you recommend their fasting. As we heard from Dr. Hassanin, patients who are classified as low risk, probably their fasting is safe and they should be able to fast. Patients in the moderate risk group, probably their fasting is not clearly certain. Then these patients would need a full medical evaluation to discuss the issue with the patient and manage them as such. And the high-risk group, clearly fasting is probably not safe. However, again, many of these patients might be able to fast. Our recommendation should be that these patients should not fast. But even the patient in the high-risk group, if they insist on fasting, then you have to evaluate them and recommend your treatment modifications and whatever needed for that. With that, let me start with the managing hyperglycemia in the patients with micro and macrovascular diabetes complications. As you know, complications are divided into two parts: the macrovascular, that will include the cardiovascular disease and history of strokes, and the microvascular disease, most importantly, the chronic kidney disease. Let me start with the macrovascular complications. Previously, we considered every patient with any cardiovascular disease as a high-risk patient, and they were advised not to fast. However, with the new evidence coming, now it looks to us that stable cardiovascular disease does not actually increase the rate of hospital admissions, and it does not worsen the outcomes. However, in regards to the history of strokes, there are conflicting evidence there, so the recommendations are not yet clear. Now, as we heard from Dr. Hassanin, patients with macrovascular complications, according to the new risk calculator, if they have unstable macrovascular disease, they should be labeled as high-risk patients with the score of 6.5, and that will say that these are high risk. If the macrovascular disease that includes cardiovascular or stroke in the past is stable, then they will get 2 points, and they will be they would not label as high risk class. Now, recommendations for patients with macrovascular disease: you have to discuss the risk with your patients. You have to modify their medications, and we heard in the previous 2 sessions about how to modify treatment. We need to get a cardiac evaluation. It's not only about diabetes control. Also, we need to get a cardiac evaluation. We need always, after we modify treatment, we need to have close monitoring for blood glucose, and we have always to consider CGM for our patients. We have to educate our patients how to manage acute complications that includes hyper and hypoglycemia, and in some patients increased ketones. Let me go now to the microvascular complications, namely the chronic kidney disease. Again, previously we considered any patient with chronic kidney disease stage 3 and more as high or even very high risk patients. Now in the new risk stratifications, we don't have a very high risk class. However, I will show you the recent guidelines. So let's review now the impact of fasting during Ramadan on chronic kidney disease. This study from Dubai Hospital showed that patients with chronic kidney disease stage 3 and more, 3 actually, they have increased risk of hypoglycemia during Ramadan. And you could see here this new 15% of hypoglycemia that was not there before Ramadan. So during Ramadan fasting, in patients with chronic kidney disease stage 3, they have increased risk of hypoglycemia. And according to the new risk stratification, now patients with GFR of less than 30, they're labeled as high risk with a score of 6.5 at least. Then you might add many other risk points for insulin and hypoglycemia and whatever. But these patients, if the GFR is less than 30, they're high-risk patients. If the GFR is between 30 and 45, they get a score of 4. And between 45 and 60, they get a score of 2. Normal GFR of more than 60, they get 0. The recommendation is that for these patients whom you know that they have chronic kidney disease, you have to identify them a few months before Ramadan, and you have to discuss the issue of fasting with them before that. Again, it's not only about diabetes. You need to discuss that with nephrology, and you need to refer your patients to be seen by nephrology, because sometimes you might think this is okay for diabetes, but many patients would be advised by nephrology not to fast. Again, pre-Ramadan counseling, actually, you should have the family also. You should discuss the case with the patient when the family is there, especially if you're talking about a high-risk patient. You have to discuss diet, physical activity, treatment modification, timing of medications, timing of insulin. You have to instruct your patients on strict blood glucose monitoring. We heard about the 7-point blood glucose monitoring. Probably you need to do that for all these renal patients. Then you need to educate them about, again, the acute complications. Again, you need to follow them up. It's not what you say the first week will apply for the whole Ramadan. You need actually to have an access for these patients to call you and to discuss with you that your changes were suitable or not. Then again, you need also nephrology to see them maybe after 1 week for further evaluation. Any patient that insists or wants to fast the month of Ramadan, or patients you recommend for them to fast because it's okay for them to fast, you have always to discuss breaking the fast rules. So in summary, for micro and macrovascular complications, fasting during Ramadan in patients with diabetes and stable cardiovascular disease or macrovascular disease does not increase the risk of hospital admissions or worsening of the underlying heart condition. However, studies on the stroke and history of stroke, they're conflicting, and we don't have a clear evidence yet. And finally, on individuals with chronic kidney disease and history of kidney transplant, these patients are at high risk for fasting. Let me move on now to elderly patients. Now, from the past guidelines, age was not considered as a risk factor alone. However, this should be questioned actually. And there were some considerations given to specific comorbidities that elderly patients have. However, we know from many studies that many elderly patients were able to fast the month of Ramadan even without any guidance. In our new recommendations now, that the risk of diabetes-related complications is higher in elderly population, and actually modifications of treatment, again, is very essential if patients wish to fast or they want to fast against your medical advice. This is a nice study. We heard about it from Dr. Hassanein previously. It looks like elderly patients aged more than 65, as you might imagine, they have a duration of diabetes of more than 10 years in 72% of them. And actually they fast Ramadan less than younger population, and they have more complications, more hypoglycemia, and more hospital admissions. Elderly patients check blood glucose during Ramadan less frequently than they do outside Ramadan. And this is really very important, and that might be one of the reasons why we don't catch their hypoglycemia and why they're admitted more frequently to the hospital during fasting. Elderly patients, as you might imagine, they have more frequent complications, hypertension, hyperlipidemia, and diabetes complications, micro and macrovascular complications. Many other considerations we have to think of when we evaluate in patients before Ramadan. We have to think about the cognitive function, physical function, ability to take medications, and feeding patterns, and whether their independence, they could make their decisions and modify their treatment the way they should do. Now, according to the risk classification tool, you could see that patients with impaired cognitive function or frail patients, they have a score of 6.5, and that by itself would place them at a high risk group. If patients are more than 70 and have no home support, we have so many of these patients are at least moderate risk, and a score of 3.5 is given for them. If they're not frail and they have good cognitive function, they get 0 score for that. Very important, as we heard previously from other presentations, all patients would require pre-Ramadan evaluation, and they need to be instructed in diet and activity. They have to be educated on well hydration during eating hours and adequate food intake, and they should limit their activity probably during the fasting hours, unless if it is very minimal exercise. Elderly patients should know that Taraweeh prayers is a part or some kind of exercise, and when we instruct them, we should consider that also. SMBG is very essential for all patients, as we heard earlier, and patients in Ramadan should increase the frequency of SMBG. Many of these patients, we should consider CGM, continuous glucose monitoring for them. We have to think of medications that have lower risk of hypoglycemia. Again, we have to modify treatment whenever indicated. We have to closely monitor these patients. And again, at Tawam Hospital, we have a hotline for our patients. When they're fasting, they contact us if they have any problem, and we manage their medications, and we titrate again, and we remodify treatment. Remember, very important to educate patients and their family on the hypoglycemia in the elderly. I mean, many of them, they have the typical symptoms of hypoglycemia. However, many patients would not get the typical symptoms. They might feel sleepy or weak, or they have trouble speaking. So you have to educate the family that this is a sign of hypoglycemia. And remember that the difference between mild hypoglycemia and severe hypoglycemia from the start of symptoms till patients lose their consciousness is very small for elderly. So they do not have time to react. That's why SMBG is really important for these patients. So in summary, for this group of patients, elderly have more frequent diabetes-related complications. Pre-Ramadan evaluation is essential for all elderly individuals. Greater emphasis on the SMBG, choose medications that have lower risk of hypoglycemia, and again, consider CGM for all these patients. Let me now go to the last part of my talk, hyperglycemia in pregnancy. And as you heard previously, pregnant and breastfeeding women are actually exempt from fasting even if they don't have diabetes, because they have the potential to have worse outcomes for the mother and for the neonate. We reported actually that even patients on diet, pregnant women with hyperglycemia, GDM here, even on diet or on metformin have increased risk of hypoglycemia and hyperglycemia. Again, these patients on diet or metformin alone. According to the new risk stratification tool, pregnant women who are not meeting their glucose or glycemic targets, they get a score of 6.5, and by definition, this is a high risk. And if they're controlled within target, still they get 3.5 points. And the reason behind that, many other, reasons, including the sake of the baby, which there are no well-controlled studies to evaluate patients and their outcomes and the babies and their outcomes. So again, when they insist on fasting, they have to know that they're at least moderate to high-risk group, and they should be referred to high-risk clinics that include a full team of OB physician, endocrinologist, nutritionist, and diabetes educator. So let's talk about the management of hyperglycemia in pregnancy for those patients who insist on fasting. Again, pre-Ramadan assessment is essential for all patients. You need to evaluate them and know if they're planning to fast or not. You're seeing them frequently, especially patients with type 1 and type 2 diabetes. You need always to discuss Ramadan fasting. And after Ramadan, also, you need to discuss what happened with them last Ramadan. You need to educate all of them, specifically on the management of complications. You need to give them a formal education on that. Physical activity and nutrition. We heard about nutrition earlier. And again, you need an expert advice on that during Ramadan fasting. SMBG is very important, and all patients must be advised on the frequency of SMBG. But remember, and we reported that relying on only meters, probably it could be misleading, because many of our patients that we're asking them to check before iftar, they're actually not checking before iftar, and they're missing the periods of hypoglycemia 1 or 2 hours before iftar. And for many of these patients, we should actually consider flash glucose monitoring or continuous glucose monitoring. Scheduling of SMBG should be before iftar, 1 to 2 hours after meals. During fasting, it should be during the first hours of fasting and also in the afternoon. And whenever these patients are not feeling well, they should check their sugar to make sure it's not hypo or hyperglycemia. It's not always about hypoglycemia. Also, these patients we reported that they have increased risk of hyperglycemia during eating hours. The targets, fasting blood glucose should be between 70 and 95, the 1 hour less than 130 milligram, and the 2 hour less than 120 milligram per deciliter. Breaking the fast rules are very important for all patients. Blood glucose less than 70 or more than 300, and very important, symptoms and signs of hypoglycemia and hyperglycemia, even if there is no hypo or hyperglycemia. Very important, feeling unwell, and specific for pregnant women, reduced fetal movement is very important, and all patients should be advised not to fast on the sick days when they have diarrhea or fever or general fatigue. As we heard from Dr. Reem, this is a similar table on how to manage insulin in pregnant women, how to modify the dose for patients on insulin pump, type 1 patients who are on insulin pump. Usually we reduce the rate of basal insulin during the day, and we increase the rate during the night, and we give the boluses according to carbohydrate counting. These patients on insulin pump should be followed up in a specialized clinic. MDI, we cut the basal insulin dose by 30 to 40%. We reported that the hypoglycemia episodes actually happen in the last few hours of fasting. That's why a 30 to 40% cut in the dose of basal insulin is a must. Then we give the highest dose of short-acting insulin at iftar time. We give half of that dose for any extra meal, and we give 2/3 of that dose at suhoor time. Pre-mixed insulin, as we heard, is not advisable to be used. However, for these patients who are using pre-mixed insulin, we give the highest dose at iftar time and probably 50% of that dose at suhoor time. And again, you need to check with the patients and modify the treatment again, depending on the SMBG. Again, give your patient an access to your clinic. We have a hotline. We could also have our educators accessible. They call them to their office, and you need always to modify treatment. So in summary, pre-Ramadan patient education is essential for all pregnant women with hyperglycemia, regular SMBG before sunset meal, 1 to 2 hours after meals, once while fasting, anytime when they're feeling unwell. Pregnant women, we spoke about the targets, and again, you have to modify their treatment and readjust modification if you observe any changes. Very important, we heard this from Dr. Hassanein, you have to think about the modifiable risk factors for your patients. In these populations, the high risk populations, you could still manage to reduce the risk for some patients. Pre-Ramadan glycemic control, very important. We reported that a good control before Ramadan is actually associated with lower complications, lower hypoglycemia rate and hyperglycemia rate during Ramadan fasting. Also, the frequency of SMBG is very essential. You might, avoid a disaster if you could do that. You educate your patients to break their fast whenever they're not controlled, and that really will improve their risk classification. Again, type of medications, you should do that before Ramadan, a few months before Ramadan. Consider medications that are not known to cause hypoglycemia, insulins that are longer acting, and probably this should be modified. And again, very, very good idea to try to fast a few days before Ramadan and reassess patients. And again, one more time, access to care is very important because patients fast and they're not sure what to do. Yes, you modified their treatment a little, maybe that was not enough. And if you don't give them access to your care, then they might get into trouble. So my take-home messages, ladies and gentlemen, high-risk populations during fasting include diabetes with unstable cardiovascular and chronic kidney disease, hyperglycemia in pregnancy, elderly with impaired cognitive or physical functions. Diabetes and Ramadan risk calculator provide a structured approach to assess patient risk. And finally, we need larger prospective studies to evaluate and validate the new data that we are presenting now. I would like to thank team members for the cardiovascular and chronic kidney disease chapter, fasting in the elderly, and also the pregnancy chapter. Thank you very much, and Ramadan Kareem to all of you.
Thank you very much, Bashar. Great presentation, very clear. Now it's time to go through the Q&A. I invite Dr. Reem and Dr. Bashar, everyone to take part. Professor Jamal, do you want to let us know what questions you want to start with?
I had two questions.
Go ahead, Ines.
One about metformin, 2 grams per day in a patient fasting 20 hours per day. And my opinion is to adopt the nearest Islamic country fasting hours, because fasting hours of 20 hours per day, according to a previous fatwa from Dar al-Ifta, is to fast according to the nearest Islamic country, because it exceeds 18 hours of fasting. So please go to, to a less rigid fatwas to fast according to the nearest Islamic agenda country. For the other question is the happening of DKA with SGLT2 inhibitors during fasting. I don't think it's an important side effect or complication, because DKA with SGLT2 only happens when there is need for insulin and the patient is not taking insulin, or in type 1 diabetic patients. So it's not a recognized side effect or complication of SGLT2 in type 2 diabetics or patients on oral hypoglycemic agents. I think so. And if any other comment from my colleagues or from Mohammed?
Yes, thank you, Ines. We have 6 studies on SGLT2 inhibitors. They're all in hot countries, either Middle East or the Far East, hot and humid. We did not see a single case of DKA during Ramadan fasting. We saw less hypoglycemia in comparison with others. Thirst would be higher, but there is no impairment of renal function or no true dehydration or markers of ketosis. But obviously you need to look into your own individual case. Just a quick remark, colleagues are asking about certificate of attendance as well as about the slides and the video. Certificate of attendance will be issued by us, and also the video will be available later on the website of IDF as well as of the organizers.
Hassanin.
Yeah.
The question about to the speakers and probably to you. What about the environment health in this evaluation of risk?
Yes.
One question. And second point is about the quality of the relationship between patient and physician. Because if the relation is good, is the patient is followed for a long time, the difficulties for Ramadan are not important. But if the patient come the first time to the physician and the physician try to change the medication, probably many problems can come during fasting.
Yes. So the first point is about the environment. Of course, in the risk categories, we as clinicians, we need to look into these points. The risk score is only a guidance, and it's impossible to put points for everything. For example, me and Bashar, we live in Dubai or UAE. The temperature is very hot, but I don't feel the heat because I live and work in air-conditioned circumstances. Perhaps someone else living in a less hot country is exposed more to the heat and to physical activity. We've quantified for the physical activity, but we did not quantify for the working hours, the temperature of where you work. These would be points yourself as a clinician would need to take into consideration and think of how much does this add to my current risk score. Obviously, it's impossible to have risk points for every single point for every single individual. This is give you some guidance. As for the other point you mentioned about the relationship of the physician and the patient, of course, going to a competent physician, a physician that you know that their opinion is regarding Ramadan is important, and that need to be, if I'm going to a doctor for the first time, I've not seen this doctor before, and this doctor will advise me on something very important to me, then I need to, of course, take the opportunity, but perhaps I need to plan to take opinion from the person I usually go to on a regular basis.
But again, I want to add here again. I mean, competent physicians are there, of course. However, we need to give them the tools to help patients. We don't have a unified way to label patients and classify patients. So this new tool probably will unify our approach to patients and will reduce the disagreement between physicians. Because many patients, they come to us just before Ramadan to ask about fasting or not. Yes. And that will be bad to give them a decision that is not unified.
And you're absolutely right, Bashar. By competent, I did not mean the seniority of the physician. I meant someone who goes through the process in a systematic way. We have provided 14 different categories with different subgroups. And if the doctor would go through all of these points, I think we will cover the vast majority of the circumstances. It's not about whether I'm 60 years old, 70 years old, I am the head of department, or I'm a junior doctor. It's about having a systematic approach. Obviously, seniority counts, but it needs to be supported by systematic approach.
Sure.
There was a question, Dr. Hassanin, I saw about type 1 diabetes. Maybe if you want to answer it through the risk scoring. I think there was someone asking, can type 1 diabetes fast, or she has type 1 diabetes?
I don't see questions. Where do you see the questions? I don't see any.
In the
chat. I don't see.
There was a
Q&A and in the chat. Two sources. The chat as well as the Q&A.
Okay.
So, Dr. Reem, if you saw the question for type 1.
There was a question on a type. Well, it was related into the risk scoring. I thought if you wanted to. So the question was, can my patient with type 1 diabetes fast?
Yeah. The three of us here.
Myself,
sure. Myself and Bashar are co-author of the risk chapter, and yourself is a co-author with us, or we are co-authors with you on the chapter on type 1. It's not, in type 1 this time, it's not about saying no. It's about going through the parameters. How well controlled are they? Are they aware of their hypos, and is their hypos not frequent or very frequent? What is their glycemic control? Do they check or not? How long is their fast? All of the points. Do they have other comorbidities or not? All of these points will allow the person to have a risk. There is no type 1 who will come as low score. They might come as moderate or as high. And then, according to the infrastructure that you have, you might be able to advise the patient of no or yes, and in either case they need to be cautious and to listen to the medical advice and apply it carefully.
There is a question for me here. For patients on sulfonylurea, would you advise not to fast or to shift to another medication? We now know that there is sulfonylurea with low incidence of hypoglycemia like glycoside MR, and this is proven in studies recently, the DAR Ramadan. So if we are using glypenclamide, we can shift to glycoside MR better than glycoside, and if not, we can use to glimepiride. So we can shift to another less hypoglycemic inducing sulfonylurea, or we can shift to another non-hypoglycemic or oral antidiabetic medication with less hypoglycemia like DPP-4 inhibitor, metformin, or SGLT2 inhibitor.
There is a question to me about a pregnant woman. It's directed to me, saying, Dr. Hassanein, I have a question. Have you ever accepted a pregnant woman to fast even with good diabetes control? Well, let me answer this question. It's not about me accepting or not. With pregnancy, there are two aspects. One is the burden. Does the lady feel this as an excessive burden or not? Second is the perfect control. Is the patient under good, perfect control or not? I don't advise any pregnant woman to fast, but that's not my decision. That's her decision. She has a license even without diabetes not to fast. So it is up to her. I work in UAE. There are a number of pregnant women who insist on fasting. What I say to them is, you carry the responsibility for yourself and for the baby. And if you're able, if you insist on fasting, make sure that you achieve these targets for yourself and for the baby as well, who has no choice in the decision that you take.
But probably very important for these patients to wear a CGM, as we reported, I mean, unrecognized or even unreported hypoglycemia in these patients, and this is really bad. I mean, if we showed these patients that they get hypoglycemic, then probably we could convince them not to fast. Otherwise, I mean, they're doing fine, they're asymptomatic, and they will keep doing, I mean, that.
And this is quite an important point that Dr. Bashar is alluding to. When you read the literatures, everyone, you will find that even non-diabetic women during pregnancy can get hypoglycemia. In the studies that were conducted both in Al-Ain by Dr. Bashar and in my center in Dubai, we saw patients on metformin or on diet who are getting prolonged hypoglycemia. This is maybe, subhanAllah, why Allah subhanahu wa ta'ala gave that license to women, because they need during pregnancy to eat frequently. So to ignore that fact is a high risk by the individual that take that decision.
Muhammad, let me add also that we don't have any long-term studies for the outcome of the fetus later on. So we don't know if the fetus is exposed to hypoglycemia during pregnancy, what's the outcome? So we need long-term studies, maybe years after pregnancy, to know if the pregnancy in diabetics is safe or not, whatever controlled and whatever medication they are using.
And that's why the general advice is take the license. I say to the lady, you're not going to be pregnant for years. So you can always compensate. And if you're unable to compensate, you could be exempt from the compensation even. If they're breastfeeding the following year and they cannot compensate for 2 consecutive years, there is a number of fatwa that is generous to say, do not compensate. So I think the essence of the religion is to protect our health and to protect our body, not to jeopardize our health and our body.
There is a question here. I'm not sure.
It's a very interesting question.
Yeah, so go ahead, Dr.
It's about, I think I was just maybe we're asking the same question. It's about the ketones in pregnancy. Is that the one?
No,
so someone's asking, do you think increased ketones during fasting in pregnant lady with type 1 or 2 or GDM is a danger to the fetus, and so we need to prohibit them from fasting? So I'm not sure. As far as I know, when we're putting patients on diet, it's advised to measure their ketones in the morning, and having positive T ketones is usually a sign that they're overdoing their diet, and it might be sometimes advised that, you know, it's time now to shift to medical therapy. But I'm not sure about if the ketones associated with fasting Ramadan specifically anybody has any thoughts on that?
I would say this is same in principle. I mean, ketones should not be accumulating, and that's a good indication to eat, I think. Now, there is a question here about, please describe the management plan of DKA. I'm not really sure if they're talking acutely or history of DKA in the past few months before Ramadan. So if we're talking about patients who had DKA in the past few months, then we're talking about glycemic control, diet, and maybe adjusting medications to avoid hyperglycemia, then CGM, and so on. If this is the question, I'm not sure if this is the question.
Inas, there's a question to you coming from Gaza, from Palestine, on glibenclamide. The person is asking, saying, we do not have other forms of sulfonylurea. Is it a must to change to other SUs, or can we decrease the dose to half?
We sometimes use glibenclamide, truly, to be honest. Yes, we sometimes use it if the patient is well controlled on glibenclamide. We reduce the dose if the patient is controlled, maybe to 75% of the dose, and to give the main dose at iftar. So it can be used, yes, because we are having successful combinations of sulfonylurea glibenclamide with metformin. And it's not usually easy to change the medication during Ramadan, then after Ramadan to tell the patient, go to your medication before Ramadan. So yes, we can reduce the dose and to change the timing of the dose.
Reem, there's a question for you on prandial insulin for people with type 2 diabetes. What is your advice?
So basically in relation to adjustments of prandial insulin, I'm assuming, short-acting insulin. And again, so the advice is generally, it depends on how the patient is taking that prandial insulin. If the patients are taking fixed doses, so the advice that, and it's like a twice-a-day regimen prior to Ramadan, or is it a 3-day regimen, a 3 times a day regimen prior to Ramadan? If it's a 3 times a day regimen prior to Ramadan, they take the largest dose with iftar, and they skip the lunch dose, and then they take the 3rd dose with sahur, with a reduction of 20 to 50% depending on the pre-Ramadan control, the previous experience, how much sahur they usually, how much carbs are in that and how much protein and all that. This is if they're taking fixed doses. For those who are already accustomed to taking their prandial based on carbohydrate counting, we advise them to continue doing so during Ramadan.
Bashar, there's a question to you about use of premixed insulin in pregnant ladies. Is it safe, or should they move to basal bolus? I mean, I suppose the question would be in Ramadan and even out of Ramadan.
Well, I mean, premixed insulin is used, probably is the most used insulin in the world. So we cannot say we should not use it. However, is it safer than the others? No, I prefer basal bolus. But premixed insulin has been used, it is used, it is safe. If you modify the dose the way we mentioned earlier, it could be, with the proper glucose monitoring, yes, it could be used. There is another question on the safety of glargine in pregnancy from Dr. Shabin. Glargine, actually, we have a good experience with glargine now, not approved by the FDA. However, we have good experience. Of course, the other insulins, the Detamir and NPH, are the ones that are approved. However, glargine looks safe, and even the glargine 300 probably is also safe at this time. Some data is coming up. So, I mean, glargine, yes, it is safe, glargine. Regular glargine, 100.
So another question to you, Dr. Reem, someone is asking about which insulin is better? I suppose it's a very general question, and perhaps you will end up repeating the full lecture again, but in very short points, tips.
I would say overall analogs are better than human insulin. The newer, longer acting, where the glargine 300 and the degludec seem to be really quite safe, with much better outcome in regards both to hypoglycemia and blood sugar control and ability to titrate safely during Ramadan. For the prandial, again, the analog short acting like the Lispro aspartame better than the regular because of the ability and the convenience of taking it very close to the meal, associated with better postprandial sugar control, in addition to less hypoglycemia.
There are lots of questions about clinical practice issues, and perhaps this is an opportunity to announce to everyone in the MENA region that there will be 3 sessions of clinical scenarios, 1 for the French-speaking region of clinical cases, 1 for the East Mediterranean region, and 1 for the Gulf region. We will email you with the dates. It will be practical case scenarios. So many of your practical hands-on questions, it will be answered during these sessions in the future, inshallah, or through the guidelines where you can log in for the IDF guidelines, or indeed watch the videos again. Professor Jamal, have you found any questions that I have missed?
There is a question here on the level of creatinine that you would not advise patient to fast if creatinine level, not GFR. Do you have the answer, guys? I'm not sure about the creatinine level. I know in GFR levels.
Yes, I mean, the modern classification of chronic kidney disease is dependent on the eGFR, which indirectly takes into consideration the creatinine itself. I'm a bit reluctant to answer, to give an exact figure of the creatinine. But as we've mentioned earlier in the presentation of Dr. Bashar, patients are considered, any patient with a creatinine above normal is probably going to be CKD stage 3 minimum. And all of these patients are advised that they are high risk, even if they are stable. Obviously, the risk will increase more and more based on the other factors such as glycemic control, frequency of hypos, type of therapy, and so on.
But there is a formula to, measure the GFR.
Yes.
Well, the question on time in range, I don't know if Dr. Bashar would like about studies on time in range in Ramadan in regards to from the CGM studies and
the time in range, they tell you now 70% is acceptable time in range with hypoglycemia less than 4% and hyperglycemia more than less than 25%. I'm not sure if there are Ramadan studies on that actually.
We have our studies that we reported on the time in range from the CGM studies that we've done. We've done 6 studies on different subgroups. But the issue with time in range, in normal days, it's fine. You're talking about the proportion of hypo to hyper. Here, any hypo incident means I need to break my fast. So it's a reflection on how frequent I am unable to sustain the fasting rather than perhaps, time in range maybe 10%. That means I have 5 minutes of hypoglycemia over 10 days, means I had to break my fast for 10 days, and that person is getting very frequent hypoglycemia. So I think time in range in Ramadan need to be taken with Ramadan consideration rather than the straightforward time in range for good or less good glycemic control in general. I cannot see many more questions that we have not answered, and we have already passed our 2 hours of time. Everyone is still there. I can see over 350 persons still there. Anyone see a question that we have not addressed?
One simple question, what is the best time for long-acting insulin during Ramadan? Tresiba or whatever, Glargine 300. What's the best time, Dr. Reem?
So, I mean, DAR guidelines specify at iftar for the long-acting insulin. But I don't. But there have been a couple of studies that didn't show that it makes a huge difference whether they keep it at bedtime, their usual bedtime, or they move it up to iftar. But I think again, it will depend on, the working hours, the sleeping hours, and so many other factors. Their previous Ramadan experience, their likelihood of having, later day hypoglycemia, and so on. But according to DAR guidelines, it's suggested to be taken at iftar.
But it actually reflects the other long-acting, the Glargine 100 and the Levemir. From a practical point of view, we just put them all in the same table. But in reality, as you've both alluded to, the ultra long-acting, the Deglodec and the Glargine 300, because of their flat and the longer duration of action, it doesn't really matter too much. But it would be nice to have the studies. What do you think, Professor Jamal? Have we finished all our questions, or is it time to close, or what do you think?
Yes, I think if there are no questions, we can close the session. And I thank you, dear Hassanin. Thank you, dear speakers, Inas Shaltut, Afandi, and Reem Al-Amoudi, and our organizer, Amber, and thank you also for the sponsor of the meeting. And you have the last word, please, Hassanin.
Thank you very much, Professor Jamal. It's a great pleasure. I can see the enthusiasm of people, and thanks for my co-speakers. Great presentations, and thanks indeed for the sponsors, Sanofi and Servier, and thanks for, of course, our organizers, Amber. And obviously, the thanks really goes to all of you attending this important sessions. We will send you, inshallah, the certificate of attendance, and the video will be available on the websites of IDF as well as of the event organizer. And we look forward to see you in future educational sessions across the region. Thank you all, and Assalamu alaikum.